And good morning, everyone. And my topic is the concept, mechanism, and the management of atrial failure. It comes from Dongfang Hospital. And first, I show you a case. She is a female, 71 years old, and she complained short of breath after exhausting and she underwent radiofrequency 4 months ago and for atrial fibrillation, and she has hypertension for more than 10 years, and her blood pressure and heart rate is normal, and there are most rails in the lung and 2/6 systolic murmur best heard beneath the xiphoid region, and there is an increase in NT-proBNP and ECG and Holter show sinus rhythm and a few ventricular premature. 4 months ago, she underwent right and left pulmonary venous ablation. And this is an echo. And we can see before ablation, and there is just a small amount of mitral regurgitation and moderate TR. And the pulmonary artery systolic pressure is just 40 millimeter mercury. But after the ablation, there is increase in the mitral regurgitation and increase in tricuspid regurgitation and PASP. But 4 months later, there is obvious increase in there is a large mitral regurgitation and a large TR, and the PSP increased to 120 millimeter mercury. The change is very obvious. And this is echo. When the patient just walking from the ward to echo lab, and we can see here the heart rate, the immediate heart rate is 104 beats per minute. And we can see from the Doppler, the pulse Doppler, we can see there is only a E wave and there is no A wave. Means indicate there is E wave and A wave just confused, fused. And from the TR jet, we can see the indicate the PSP is 110, and C and D is just after rest of the patient, just after rest, and we can see the heart rate decreased to 87 beats per minute, and we can it's very surprised, and the TR jet from the TR jet we can see the PSP just significant decrease to 39 millimeter mercury, and this is the change is very obvious, and this patient is atrial failure. And this is another patient with history of hypertension. We can see the atrial and atrial ventricular synchrony. And from the echo, we can see there is only E wave and no A wave. The atrial is stand still. So with this change and because the atrial doesn't work, so the blood stasis and the decrease the booster pump, and from the Garlate MRI, we can see there is a tensile atrial tissue fibrosis, and the atrial fibrosis will decrease the compliance of the heart and will increase the endothelial dysfunction. And so for many years, the atrial has been quite neglected by researchers, and more recently, the left atrium has gained great attention with the development of intervention therapy of atrial fibrillation. It has crucial role in the hemodynamic of heart. So recently, it's proposed that atrial failure as a clinical relevant entity. What is the atrial failure? And any atrial dysfunction, including anatomy, mechanical, and electrical, causing impaired heart performance and symptoms and worsening quality of life and life expectancy in absence of significant valvular or ventricular abnormalities. And we know left atrium has two parts, the posterior superior inflow and anterior inferior outflow components. The 3D symmetric configuration of the symmetric pulmonary vein function attachment allows special vertical flow pattern favor early diastolic airway filling while avoiding blood stasis. And there is three kind of airway function, including reservoir function, conduct function, and boosting pump function. And inflow to the left atrium from the pulmonary venous occurs during left ventricular systolic and also volumetric relaxation and account for approximately 40% to 50% of left ventricular stroke volume. And the conduct function is just a passive blood transfer during left diastolic constitute approximately 20% and 30% of stroke volume. And the booster pump function just precede the active atrial contraction, which transferred the remaining volume to the left ventricular. And there are several cause and trigger of atrial failure, including atrial dysynchrony, including AV dysynchrony and left bundle branch block and first degree AV block and suboptimal pacemaker promising and atrial dysynchrony and including advanced atrial blocking and slow intra-atrial conductor velocity, and the boost pump and the reservoir dysfunction, including fast and disorganized atrial activity, atrial fibrillation, focus, re-entrant atrial tachycardia, and extensive atrial fibrosis, including advanced atrial remodeling, extensive post-ablation scar, and atrial infarction and atrial cardiomyopathy. Impaired conduct function, including severe atrial dilation and spherical atrial disformation and altered transmitter pressure gradient. And this patient with ischemia cardiomyopathy and paroxysmal atrial fibrillation presenting with exercise intolerance. And the ECG show P-wave duration increased and with advanced intra-atrial block pattern. And the transmural pulse echo show normal filling pattern at rest. However, a complete fusion of EVL and AVL at 100 beats per minute. And this means atrial failure. And this is contribute to worsening of the symptom and global heart performance, and left atrium mapping revealed initial septal activation only and with no contribution of the intra-atrial Bentham bundle and coronary sinus connection. And also atrial cardiomyopathy, and it will include idiopathic and is associated with increased fibrosis, atrial arrhythmia, and impaired atrial function, and induced stiff of the left atrium symptom after ablation, estimate accounting for approximately 2% to 8% of case, and atrial ischemia and myocarditis, and etc. And atrial remodeling, including cardiac condition and non-cardiac condition, and the cardiac condition including atrial fibrillation and ventricular valvular disease, and the non-cardiac including sleep apnea syndrome and hypertension, diabetes, and obesity. And this is the cause, mechanism, and clinical manifestation of atrial failure. And we can see if there is left AV dysynchrony and left atrium dysynchrony and all extensive atrial fibrosis, and all this will induce electro dysfunction, booster pump failure, and reservoir dysfunction, and decreased conduct function, and the lungs atrial failure, and it will increase thrombus and decrease airway left ventricular hemodynamics and increase pulmonary hypertension, and thus increase stroke, ischemia, and heart failure. And in some instances, heart path may be the consequence of a failing left atrium. About 45% of patients presenting with new onset of heart failure symptom have left atrium dysfunction as the underlying mechanism, suggesting that left atrial failure is an early driver in the HPAF syndrome and a critical pathologic factor. In addition to mechanical left atrium impairment driven by increased stiffness and pressure of pulse, electro atrial dysfunction and paired LA and LV coupling could play a relevant role in the patients with HPAF. And also, thrombus event is very important in atrial failure, and the lack of association between the timing of atrial fibrillation episode and the strokes suggests that atrial failure can be a marker of atrial myopathy rather than a cause of thrombus formation. Here we can see from data of MERS population show a strong association between the atrial reservoir function and the indicate of ambulance event. We can see with the increase of the LAEF, and there is a decrease in ischemia, cerebral ventricular events. And this is the summary, and we can see with this kind of disease, valvular ventricular cardiomyopathy and hypertension and obesity, and this will increase the left atrium remodeling, and also atrial cardiomyopathy, and all this will increase the dilation of the atrium and decrease the reserve and bursting pump of the atrium and increase the fibrosis, and all this will make increase the blood stasis, so the stroke happened. And how to assess the left atrium function? There are several, like at the 3D echo and cardio CT and cardio MR, and with 2D or 3D echo, there is advantage of real-time imaging, and he can also to do the left atrium function just for real time, and for coronary CT. We can have excellent image of left atrium geometric and left atrium size, and for cardiac MR, we can also has excellent LA geometric and LA size, extremely in the tissue characterization. And this is the echo. We can use the echo indicator to suggest the left atrium function. And this is the left atrium stream. And this is the summary. The summary, we can see that this is the pulmonary venous velocity and LV strain and LA volume and the pressure and also ECG. And the red curve indicate the reserve function, and the blue curve indicate the conducted function, and this is yellow. Yellow is the booster pump. And this is the summary for the diagnostic state and potential interventions, such as the risk for stroke. We can identify non-atrial fibrillation individual at risk of stroke, and identify atrial fibrillation individual at low risk, and suggest some or anticoagulant may be indicated in the individuals without atrial fibrillation and discourage in patients with atrial fibrillation. And for heart failure, and we can identify mechanism of heart failure syndrome in the absence of left ventricular abnormalities and tilted heart failure treatment and upstream therapy to the reduce fibrosis. And we can also for the atrial fibrillation management to select of candidates for rhythm control and rhythm control. And this is the concept of atrial failure, and it's time to appreciate the role of atrial dysfunction in the symptom of many of patients, marker, aggravating factor, concept, and primary cause. And it is and the concept of atrial failure may foster the basic and transition research, gain a better understanding of how to identify and management of atrial dysfunction in the future. Thank you.